Good morning, ladies and gentlemen. This is Paolo D'Amico. I'm a medical doctor, and today I'm going to present preliminary results of our collaborative project that is going on between the Northwestern University and Università degli Studi di Milano. The title is Implementing a Novel Biomarker to Define the Role of HER2 CTCs in Metastatic Breast Cancer, the Circulating Air-to ratio. This project has been supported by the American-Italian Cancer Foundation. So, since early 2000, we are using the cell search, that is the only FDA-approved machine, to enumerate and characterize circulating tumor cells in breast cancer patients as well as other cancer. And this is possible thanks to Professor Christopher Neely and other investigators that have demonstrated their prognostic value in 2004. We have been using 3 channels to enumerate CTC, but actually this machine gave us the possibility to further characterize circulating tumor cells with an additional antibody detection that is detected by the so-called 4th channel. The most relevant biomarkers has been tested using this channel in order to investigate the potential prognostic or predictive value of this further characterization of CTCs. But in this presentation, I will focus only on HER2, which expression in tissue is a well-established predictive factor of response to anti-HER2 treatment that, as we know, has positively overturned the prognosis of a subpopulation of metastatic breast cancer patients. So my question today is there any chance to identify through a liquid biopsy biomarker an additional population of patients that may benefit from this targeted treatment? But first of all, let's quickly review where we stand. So which are the clinical evidence supporting the use of HER2 expression or amplification in circulating tumor cells to recognize this portion of HER2 negative breast cancer patients based on tissue biopsy that may benefit from targeted treatment. This is the design of the CIRCE-TDM1 trial where HER2 negative metastatic breast cancer patients with HER2 amplified CTCs were treated with TDM1, that is an antibody drug conjugated against HER2. The overall response rate, that was the primary endpoint, was quite disappointing, only 11%. And there were other 4 patients achieving a stable disease by this drug in this contest among 11 patients. The supply actually of the FISH CTC assay discontinued the development in 2016, and the investigators had to stop the enrollment prematurely. So the curves that you see here are progression-free survival and overall survival, and as being compared with those that did not have HER2 positive CTCs and that were treated per standard of care. So you can deduce that actually they were definitely 2 different subpopulations treated with different therapies, so they were incomparable. This trial, in my opinion, has underlined the importance to have a well-recognized, a well-established, standardized method for CTC characterization. So we have the bad and we also have the good. In this case, this is a phase 3 randomized trial that has assessed the efficacy of Lapatinib when administered in HER2 negative metastatic breast cancer patients that were bearing HER2 positive CTC. The preliminary results were published recently at the last San Antonio Breast Cancer Symposium, and we see that patients were randomized either to receive standard of care or standard of care plus Lapatinib. This was the first phase 3 trial that have demonstrated a gain in terms of overall survival for these patients. We have a difference. If we administered Lapatinib plus standard of therapy in this cohort of patients, we have a gain in overall survival. In this case, HER2 expression was assessed using the cell search, and only HER2 positive 3+ CTCs were considered HER2 positive. So there were a very strictly selection in patients. However, something remained unclear, because if we consider progression-free survival, that we know is a surrogate of overall survival, the curves are almost overlapping. So there is no difference. There is still something, in my opinion, in the process of understanding the role of HER2 positive CTCs that is missing. We still miss something. But what happens if we start taking in consideration the different intensities of HER2 expression in circulating tumor cells? What happens if we consider the heterogeneity of HER2 expression within CTCs of the same patients in the same blood draw? The same patient may have different CTCs with different HER2 expression with different intensity for HER2. So to address this question, and we know that almost the majority of the patients have this condition. There is very few patients has homogeneity of HER2 expression in CTCs when they have it. So to address this question, we created this new simple algorithm that we called the circulating Air-to ratio, that is defined as the sum of 2+ CTCs and 3+ CTCs divided by the total number of HER2 positive CTCs. Using this algorithm, we both are taking in consideration CTCs with HER2 intensity that are different than 3+, but we are also taking in consideration the mutual proportions, because we take in consideration how many 1+ a patient has and how many 3+, etc., etc. So please take note that the ratio goes up when we have few HER2 1+ CTC and goes down when we detect more 1+ HER2 positive CTCs. So we started from this point. Given the fact that the concordance between a liquid biopsy based biomarker and the expression of the same biomarker in the corresponding tissue biopsy has been often used as a parameter of reliability of the liquid biomarker, we wanted to compare the circulating HER2 ratio with the mere detection of HER2 positive CTCs of each different intensity of expression with their power to predict an HER2 amplification in the corresponding tissue biopsy. So, are HER2 positive 1+, 2+, 3+ good CTCs to predict the HER2 positivity in tissue biopsy? The concordance is very low. We know that even if we consider only 3+ CTCs, the concordance with the tissue biopsy is low. But actually, we noticed that the circulating HER2 ratio has a quite satisfying performance, definitely higher than the other biomarker assessed, identifying an HER2 positive disease on tissue biopsy, and we got an area under the curve ROC of 0.73. That is the best we got when compared with the other biomarker that we wanted to test the performance in this preliminary study. So notably, the performance is higher even if compared with the HER2 3+ CTCs. So, encouraged by these findings, we performed a retrospective study of metastatic breast cancer patients, 300 metastatic breast cancer patients that received a blood draw for CTCs analysis with cell search, and their CTC were stained for HER2. We selected those that were considered aggressive, so that had more than 5 CTCs in a tube, and we consider only the one that had at least one HER2 CTC of any intensity, so 1+, 2+, and 3+. Then we split the patients in two different subgroups of patients. The circulating HER2 high, for those who had a ratio higher than 0.75, and the circulating HER2 low for the others. And we compare them. If we compare the distribution of subtypes among these two subpopulations, we notice that a higher percentage of circulating HER2 high patients is actually HER2 amplified in tissue. And we already knew that. 38% versus 19%. There is a higher prevalence of HER2 positive patients among these. But in order to confirm these findings, we collected data from circulating tumor DNA analysis and of these patients, and we compared the prevalence of HER2 alteration that we found on the circulating tumor DNA, and we found that surprisingly, half of the patients in the circulating HER2 high cohort had detectable HER2 alteration, compared with only 23% in the other cohort. So I will raise a provocative question now. Based on this evidence, which group would you think may respond better to an anti-HER2 treatment? Give your best guess. But what about the other population? What about the circulating HER2 low subgroup? They are characterized by a higher prevalence of endocrine receptor positive patients and a similar percentage of triple negative breast cancer. So based on this statement, again another question, which population would you expect to have a better progression-free survival to the next therapy? Probably the one with more endocrine receptor positive tumor that we know have a better prognosis. So the circulating HER2 low subgroup. Remember, these patients are the one that have more HER2 1+ CTCs. But if we compare the progression-free survival of the two subpopulations, we actually notice that the circulating HER2 low patients have a significant worse prognosis. So it's in contrast to what we thought before. So brief recap, patients with circulating HER2 high ratio have a better prognosis, are characterized by factors of favorable response to targeted treatment, and so on. Patients with circulating HER2 low ratio, they have more HER2 1+ CTCs, are more likely to be endocrine receptor positive, and they will probably be refractory to the therapy that we receive. But let's go deeper in the characterization of these two subgroups. Can this biomarker tell us more about the disease? Can we understand more? Can we know more using this biomarker? If we take a look at, for example, at the metastatic burden, that is both visceral in this case and not visceral metastasis, we find that the patients that are in the circulating HER2 low group, they are characterized by fewer sites of metastasis. So there is a fewer percentage of oligometastatic patients. In this case, we define oligometastatic patients as those who has less than 2 different sites of metastatic involvement. But what kind of metastatic behavior this population has? Can we identify a trend using this biomarker? Here we go. This is the visceral involvement by site for both the populations. The circulating HER2 low patients are affected by a disease that looks like seems to have a particular tropism towards specific site of metastasis. There is a higher incidence of liver, lung, and lymph nodes metastasis. Again, circulating HER2 low patients, more HER2 1+ CTCs. disease with multiple sites of metastatic involvement, trophies toward liver, lung, and vital organs. Worse prognosis. Is that enough to start thinking that we should give more relevance, more importance to this subgroup of cells of HER2 positive CTCs that have been so far neglected? Are they just HER2 negative CTCs, or they are actually a biological entity whose role should be addressed in future investigations? I would love to share with you where we are with our preclinical investigation toward this direction, but I suppose I ran out of time. So I want to thank you for your attention and stay tuned to this channel for the next episodes.